I would like for you to think of yourself for just a moment as a patient. You're laying in an emergency department, you can't move your right side, and you're having trouble getting your words out. You're having a stroke. Your doctors are getting treatment started, but you've seen this play out before, and you don't know what direction this is going to go. You start to think about your own mortality, but even more so, you start to think about what your life is going to look like when you do survive this and how much it's going to change. What if I told you at that moment that I could give you a healthy day, that I could give you a day at normal function or near normal function? At that moment, when you're laying in the emergency department with stroke, what would you do with that day? Would you get out and enjoy nature? Would you have your favorite food or drink? Would you reconnect with old friends? Or would you surround yourself with family? It's not one answer. We might do all of those things. Everybody's got a different thing that they would do. There was a study published just last year, a meta-analysis in JAMA Neurology, that looked at patients with an acute ischemic stroke due to a large vessel occlusion who had mechanical thrombectomy performed within 4 hours. And in that group of patients, they found that for every 10-minute delay in time to mechanical thrombectomy, that patient lost, on average, 1.8 months of healthy life years. Now, that works out to, the authors point out, for every 1 second in delay, the patient will lose 2.4 hours. In other words, for every 10 seconds in delay in time to mechanical thrombectomy reperfusion, the patient would lose 24 hours or a day of healthy life. Now, that's a pessimistic way of looking at things. I like to look at things in the opposite way. I like to think that if I can diagnose quickly that ischemic stroke due to a large vessel occlusion and in a timely manner get that patient to wherever they need to be to have that mechanical thrombectomy performed, for every second or minute or hour I save in doing that efficiently, I can give that patient days or weeks or months or years of healthy, high-functioning life years. Now, I know that sounds a bit dramatic, but that's what the numbers show, that by getting this done quickly, we can make a difference in our patients' lives. My name's Bart Besinger. I'm an emergency physician. I'm an associate professor of clinical emergency medicine at Indiana University, and our topic today is endovascular therapy, state-of-the-art stroke care. Now, it's important for me to point this out because the things we're going to talk about today, I'm sure, involve lots and lots of money, and none of that has anything to do with me. I don't have an ownership stake in any of this stuff. I don't take any money from industry. I have no conflicts of interest whatsoever. As I mentioned, we're going to be talking about state-of-the-art stroke care with a focus on endovascular therapy. Now, I know as emergency physicians, we love to sit around and endlessly debate the value of thrombolytics. Are they good? Are they bad? Do they help? Do they hurt? Do they save? Do they kill? We talk about this all the time. We've been doing this for 2 decades, by the way. I think at this point, most people have made up their mind. The world has certainly made up its mind. It's become something that we do in standard fashion. So I'm not going to touch on that debate today. And I would point out that not much has changed with thrombolytic therapy in the last couple of years at any rate. Endovascular therapy, on the other hand, over the last several years has been an absolute revolution in how we take care of patients with stroke. And it continues to evolve at a pretty rapid pace. So my goal today is to bring you up to date with all of that. Now, it wasn't that many years ago that endovascular therapy done by interventional radiologists was something relegated to the tertiary care center. Something that, yes, they did it in comprehensive stroke centers, but for most of us taking care of patients in most emergency departments, really wasn't something we had to absolutely consider. That's all changed. Right now, no matter where you practice, no matter your practice environment, you need to consider for every stroke patient that you see, does this patient have a large vessel occlusion, and might they be a candidate for endovascular therapy for their stroke? It's often said to us in emergency medicine that what you do matters, and that is true, it does. But I think there's a corollary in many cases, and certainly in this one. and that is where you do it matters too, because how we handle a patient with a large vessel occlusion ischemic stroke is going to be different in a comprehensive stroke center than it is in a primary stroke center that may or may not have the ability to do mechanical thrombectomy, and certainly than it is in a critical access small hospital that has very limited resources. But we need to know how to do it wherever it is that we work. So let me share a little bit about where I work so you know where I'm coming from. I do some shifts in critical access hospitals. I did one just a few days ago. So I have some appreciation of the challenges of that environment. Most of what I do is in a larger hospital, a tertiary center that is also a comprehensive stroke center. So we're lucky, we have all the things. We have around-the-clock neurointerventional radiology. When I call a stroke alert, a neurologist or at least a neurology resident is at the bedside within a few minutes. I've got all the radiology tools I might want. I've got a pharmacist in the emergency department to help dose TPA. And I have this thing. I have a stroke ambulance. It's called the Mobile Stroke Unit. And this is an ambulance that has on it a CT scanner, a neurologist, and TPA. So sometimes I'm seeing patients that have come from the field and have received TPA before they get to me. I understand that most of us don't practice in that sort of environment. So you will need to think about things differently than I do sometimes. No matter where you are, though, no matter what environment you're in, the key thing is that you have to have a protocol. Going to talk about a lot of different strategies, a lot of different ways of doing things, and the evidence behind them today. But these are not decisions that are best made at the bedside in the heat of battle. These are things you have to have planned ahead for. So your hospital has to have a protocol to deal with these patients. Most of you do already, or at least hopefully you do. If you don't, go back now and talk to the other people in your hospital, in your department, in your healthcare system to work one out. So have a protocol. It's important that you as a bedside frontline clinician know the protocol, and of course, whenever clinically reasonable to do so, that you follow the protocol. All of our protocols draw heavily on this document right here. This is the combined American Heart Association, American Stroke Association guideline for the management of patients with acute ischemic stroke. It was last updated in 2019, and that was an update of a major rewrite that occurred in 2018, and this is our most current guideline. I'm going to be drawing on this heavily today as we talk through things, and you'll notice right down here in the bottom left side of the screen, there is a reference, the journal, the year, the PMID number. You can easily look these up. You're going to see these peppered throughout my talk. When there are important papers that I think might be of value to you, I have them right there for you. We're going to try to keep things fairly conceptual today and not get too deeply into the evidence-based weed of statistics and numbers. If you want more information, please, by all means, these are some good papers. Look them up. All right, so who is eligible for a mechanical thrombectomy in the first place? Well, you have to have a large vessel occlusion. So if you have a stroke that's due to some small branch artery or due to a little lacunar stroke, there's not technology to go up there and take that clot out. Mechanical thrombectomy, endovascular therapy only works for large vessel occlusion. So what are large vessels? Well, if you look at this schematic here, coronal cross-section of the brain, we can see we have the ICA, the internal carotid artery, branches to the ACA, the anterior cerebral artery, and then to the MCA, or middle cerebral artery, which is divided into segments. They're just numbered, M1, M2, M3. Some people describe it M4 as you get more distal. And then I have listed over here the posterior circulation, the PCA, the basilar artery, and the vertebral arteries. All of these are technically considered to be large vessels, and patients with strokes due to occlusions of any of these vessels may potentially be a candidate for endovascular therapy. But the two big ones are the internal carotid and the M1 segment of the MCA. These are the most well studied. Every study essentially that's looked at mechanical thrombectomy for acute ischemic stroke includes these two arteries. All the other arteries on this screen, sometimes they're included, sometimes they're not, so the data is not going to be as clear for those as we're moving forward. But M1, ICA, always included. Why are large vessel occlusion strokes so important? Well, one, they're more common than you might think. Using a fairly liberal definition of what's an LVO, including all the stuff that we had on the screen just in front of this, almost 40% of acute ischemic strokes are due to a large vessel occlusion. So this isn't a once-in-a-while thing. This is a very frequent thing that we will encounter. So they're important because they're common. They're also important because they're bad. As you might imagine, the bigger the vessel the stroke is in, the worse that patient is going to do. These are the bad strokes. Mortality in large vessel occlusion strokes is 26%. Mortality in non-large vessel occlusion strokes, less than 2%. It's a big difference. Bad outcomes, modified Rankin score of 3 to 6. So just to refresh your memory, Modified Rankin score isn't something we use in the emergency department. It is a long-term measure of outcome, usually done at about 90 days, with a score ranging from 0, which is completely asymptomatic, to 6, which is dead, and then all the numbers in between. So 3 to 6, these are patients that are pretty gravely disabled or dead. In LVO strokes, over half, 64%. In non-LVO strokes, much less, only 24%. So these are the bad strokes, but you might be saying, that's what untreated strokes look like. But we got TPA. What if we give TPA to these strokes? TPA does not work well for large vessel occlusion strokes. Works much better for these small branch artery kind of strokes. When you look at recanalization rates after the administration of alteplase for an acute ischemic stroke, in the M2 segment of the MCA, only about 30 to 40%, less than half the time, will it result in recanalization. In the internal carotid artery, even more dismal, only 4 to 8% of the time. So a minority of these large vessel occlusion strokes are achieving meaningful reperfusion with the administration of TPA. So the worst strokes are not well treated by the current therapy that we have. Let me pause here. I've been throwing some terms around. Let me explain a little bit what some of them mean. So we're going to talk about endovascular therapy, which is a generic term essentially for anything that an interventional radiologist puts a catheter into the vessels of the brain and does. Two big categories. One is intra-arterial TPA. You've probably heard of this. The data is not nearly as clear for this. And so this is not, it's done sometimes, often in research centers, not done as frequently. Maybe it will be a promising therapy, not as well studied as the other. Mechanical thrombectomy, on the other hand, is generally what we do. It's generally what's done. It's any process by which the clot is mechanically removed from a cerebral artery. Two main types. One is catheter aspiration, sucked out, and the second is a stent retriever. There are some other devices, older devices, didn't seem to work as well, more of historical interest, but these are the two that we will commonly be doing. So you can understand why there was excitement from this. We got large vessel occlusions that cause significant strokes. It happens very commonly. TPA doesn't work very well. We know in heart attacks, if we go up with a catheter and take a clot out and put stents in and do all that stuff, that works amazingly well. So can we do the same thing for the brain? You know, this is something that occurred to a lot of people a while back. And almost a decade ago in 2013, there were 3 big studies that were published looking at mechanical thrombectomy for acute ischemic stroke. And you may be surprised to hear all 3 of them showed no benefit whatsoever to this therapy. They did not show a good outcome overall in these patients. There were some hints that in some patients it might work, but it didn't show an overall benefit. So you may be wondering why we are doing it today. Well, things change. So there were 2 big changes that have occurred since these studies were done. One is patient selection. We'll dive into that a little bit, but they use clinical criteria to decide who to attempt this therapy on rather than radiographic criteria demonstrating the patient had a large vessel occlusion in the first place. The second big change is that the technology has improved. There are newer devices that seem to work better. So in 2013, the published study said, this doesn't really seem to work all that well. New technology has changed that. The stent retriever I mentioned earlier, just to give you a sense of what it is a sheath-covered stent that is deployed into the cerebral vasculature into the offending clot. The sheath is then retracted, deploying the stent into the clot, and then the stent is pulled back with the clot in it. Simple as that. I make it sound more simple than I'm sure it is, but that's basically the concept of what it is. And I mentioned the other big change is this idea of patient selection. We said that mechanical thrombectomy is only going to work if you have a large vessel occlusion to go after in the first place. So the question becomes, okay, which of my patients has a large vessel occlusion? As we stand here in 2022, the answer to that seems very obvious. You do a CTA or an MRA or some other non-invasive vascular imaging study. But that's not what they did in those 2013 studies. They basically said, listen, we know that large vessel occlusions cause the most severe strokes. So let's come up with some cutoff, some definition of severe stroke, and we'll take those patients and enroll them in this study for mechanical thrombectomy. So, of course, they get those patients to the IR suite, and some of them don't even have a large vessel occlusion, and those patients are counted in the final analysis. There was signal in these studies, though, of the patients with an LVO, they did receive some benefit, but they included a lot of patients who ultimately did not even have a large vessel occlusion. Can we do this? Can we predict who has a large vessel occlusion? And this is an important question even today, because as emergency physicians, we have to decide who are we going to work up to see if they have a large vessel occlusion. So can we use clinical criteria for this? Well, there are a number of scoring systems to help us out, and they help us some, but they're imperfect, as we'll see. I have 4 of them listed here. There are many others, and it's a little rule of mine that if you have 12 different decision instruments for one clinical question, then you have 0 clinical decision instruments. Because if you had one that worked, that would just be the one. In this case, we have lots of them. So these are some of the more common ones: Cincinnati Pre-Hospital Stroke Severity Scale, the RACE, the Los Angeles Motor Scale, and then the one we know probably the best as physicians in the emergency department, the National Institutes of Health, or the NIH Stroke Scale. These all seem to perform about the same. They've been all studied head-to-head. None of them seems to have any superiority. So let's focus on the one that we do in the emergency department, the NIH Stroke Scale. Just a quick pause to talk about the NIH if you're not as familiar with it. The NIH Stroke Scale is an 11-item physical examination scale. You do 11 items on the physical exam. You get a certain number of points for each finding. And then the final score for the stroke scale is a number somewhere between 0 and 42 inclusive. 0 meaning no symptoms or no findings on exam whatsoever. I shouldn't say no symptoms, no findings on exam whatsoever. And 42 would essentially mean comatose, not doing anything. The higher the number, the more severe the stroke. If you're not doing this for your stroke patients, you should be. We should be. It's a little bit of a pain to do, I'll be honest with you, but I forced myself to learn to do it, and I'm glad that I did. It's important for a number of reasons. One, in the research studies looking at various therapies for stroke, this is what they used when they described who the patients were. Two, it provides an objective measure that will tell you about changes in their clinical course over time. So it's one thing if the nurse comes to you and says, hey, I think your stroke patient in bed 4 is getting a little worse. You can go in, you can do another stroke scale examination, and in an objective scored manner, describe if that patient's worse, better, or unchanged. That's an important reason to do it as well. It's also important because it's predictive of outcome. The higher the NIH score, the worse that patient's going to tend to do in the long term. And I think the real big reason is it's the language neurologists speak. As emergency physicians, we have to do this. When I call an orthopedist to tell them what kind of fracture my patient has, I need to be able to describe that in their language. Same thing here. NIH score is the language that neurologists speak. Knowing that score and communicating it to them facilitates the conversation and facilitates the care of that patient. Again, it's a little bit of a pain. Unless you do these all the time, I think it's very hard to remember all the steps. This is a great opportunity to pull up your favorite medical calculator on your phone, and that's what I do. I stand at the bedside, and I just go through the medical calculator as I'm doing it. American Heart and American Stroke Association recommend that we do this on every stroke patient that we see. But the question is, can it predict who has a large vessel occlusion? Again, it provides us some information, but it doesn't predict with outstanding clarity. So the most often used cutoff score is 6. And if we look at patients that have an NIH of greater than or equal to 6 and ask the question, do they have an LVO? It's reasonably sensitive, 87% sensitive. Pretty good, but it's still going to miss, if we use this cutoff of 6, a significant number of patients with large vessel occlusions who might benefit from endovascular therapy. And it's not very specific at this level, 52%. We increase the score to 10. As you might anticipate, our sensitivity goes down and our specificity goes up. So it's really not any more useful at that level. So the short answer is we can predict to some degree, but we can't rule it out based on any of our clinical scoring systems. All right, so let's move ahead a little bit. So we're out of 2013. We're now in 2015. And in 2015, 5 landmark studies, and I would call these all landmark studies, were published looking at endovascular therapy for acute ischemic stroke. And these studies all shared something in common that none of the 2013 studies did. And it was patient selection driven. The patients enrolled in these studies had to have radiographically proven large vessel occlusion. So it wasn't enough to say, yeah, I think they do because it's a pretty bad stroke. They had to have imaging that showed a large vessel occlusion. Now, other than that, these studies were fairly heterogeneous. So they're summarized in Lancet in 2016, a very nice meta-analysis of these studies, and it pointed out this heterogeneity. Some studies used a time cutoff of up to 4.45 hours after last known well. Some studies went all the way up to 12 hours. They included different arteries. They all included, not surprisingly, the ICA and the M1 segment. Inclusion of other arteries was a little bit more variable. It's important to know, though, that when you pool all these studies together, 90% of the occlusions were in either one of those two places, ICA or M1 segment of the MCA. Some patients got thrombolytics before thrombectomy, some did not. Little point of confusion on that. That's some controversy that we'll dig into here in a minute. So some did, some didn't. But in general in these studies, if patients were eligible for thrombolytics, they got them before they went for endovascular therapy. Some patients weren't eligible. Again, one of these studies went up to 12 hours after last known well. Many of those patients, all of those who presented after 4.5 hours, are not going to be eligible for thrombolytics. And then other patients had the usual contraindications, recent surgery, they're on warfarin, whatever, and were unable to get it. So patients who could get thrombolytics did, but not all patients got thrombolytics. So how did this do? When these studies are pooled together, the 2015 studies looking at mechanical thrombectomy, they found that for excellent outcomes, modified Rankin score of 0 to 1, so no disability or minimal disability, 27% in the mechanical thrombectomy group, but only 13% in the control group. That works out to a number needed to treat of 7 to get one more outstanding outcome. So pretty impressive that this is a therapy that works. And when this data was published, the American Heart Association, American Stroke Association, they jumped on this right away and said, we have 5 good studies here that show this works. We need to change our guidelines. And this is a guideline that is true as of today. It is a Class 1A recommendation, the highest level, that for patients who have an occlusion of the ICA or M1 segment of the MCA and an NIH score of greater than or equal to 6, and treatment can be initiated within 6 hours of last known well, mechanical thrombectomy is a level 1A recommendation to be performed. It's a game changer. We'll have to think about this with all these patients now. Now, what about patients that don't quite meet these criteria? Well, there's some wiggle room there. The AHA-ASA says it may still be reasonable to perform a mechanical thrombectomy on patients who have a large vessel occlusion, but they have an NIH that's a little bit lower, say 4, say 5, but still significantly disabling. Or if it's in one of these other large vessels, it may still be reasonable to do so. So we have to consider it even in this group of patients. Other side of this is, can there be harm? Absolutely. Anytime you stick a catheter in a vessel, bad things can happen. Vessel rupture, vessel dissection being 2 of those things. Fortunately, these studies, the harm rates were fairly low, less than 2%. It's important to remember, though, that any harm that occurred that might have caused downstream bad outcomes, that's baked into the final results. Those final outcomes of modified Rankin scores account for the fact that some of these patients may have been harmed. They're included in that analysis. So even though there's a small risk of harm on balance, still significant benefit for this therapy. What about other harms? Mortality, lower in the mechanical thrombectomy group than in the control group. Symptomatic intracranial hemorrhages. We know that's always a problem when we treat stroke. Mechanical thrombectomy does not seem to make that worse. The rates were roughly the same for mechanical thrombectomy as they were for controls in terms of who developed an intracranial hemorrhage. So the safety seems to be there too. So we accept that this therapy is helpful and beneficial for our patients. So who do we need to work up to see if they have a large vessel occlusion? Well, there are a couple of things to consider here. The other question is, when in the process do we do that workup to see if they have a large vessel occlusion? In terms of who we do it on, we have to again remember that the clinical prediction model of finding an LVO is fairly poor. We can get some helpful information, but we cannot rule it out based on clinical grounds. So we need a liberal approach to getting a CTA on all patients who might conceivably have a large vessel occlusion. I will tell you, at my institution, it's simple. If you come in as a stroke alert with acute onset of stroke-like symptoms, you get a CTA with your non-con head at the same time immediately early in your workup. And I think that's a very reasonable protocol to have. Your protocol may be a little bit different than that, but it needs to very liberally include non-invasive vascular imaging to identify those LVOs. When do we get it? It's a tougher question. We have to consider a couple things. One, as we talked about at the very top of this lecture, there is a critical time dependency to getting that mechanical thrombectomy performed. So the earlier we can get the CTA and prove the LVO, the earlier we can get them onto therapy. But some of these patients are going to be getting TPA, and TPA is also time dependent. So we don't want to do the CTA early if it is going to delay the potential administration of TPA. So what do the guidelines say? Well, I think they're somewhat straightforward here. So the guidelines say that for patients who otherwise meet criteria for thrombectomy, non-invasive vessel imaging of the intracranial arteries is recommended during the initial imaging evaluation. So right away, they come in, they look like an acute stroke, send them for CT, non-con, and CTA at the same time. So as the initial, and they give that a level 1A recommendation, but they give some wiggle room here and they say, if they have a suspected LVO and they didn't get non-invasive vessel imaging initially, then it should be obtained as quickly as possible, even including when they're getting TPA. So they get their non-contrast head. If they're eligible for TPA, get started, get them back right away and get that CTA to see if there's an LVO. Now, for those of you who are not doing the CTA right away as part of your initial study, I think I have a feeling why that might be, because I work in an emergency department too, and I know that the radiology department does not love it when we give people contrast without having a creatinine and a GFR first. So the American Heart Association, American Stroke Association give us some cover here, which is really nice. In patients with a suspected LVO and no history of renal impairment, it's reasonable to proceed to CTA if indicated before obtaining a serum creatinine. So as you're putting together your protocols, this is worth keeping in mind and sharing with your radiology department. Hey, brain trumps kidneys here. Unless there's some reason to suspect there's renal impairment, we should be getting the CTA right away so we can shorten that time from door to mechanical thrombectomy reperfusion. The bottom line with all this, again, is most strokes that are less than 6 hours from onset deserve a CTA. Get it as quickly as possible within the constraints of your institution and your resources, and of course, follow whatever protocol that you've developed. So we've gotten our CTA, and we have identified large vessel occlusion. And then a question becomes, okay, this patient's a candidate or potential candidate for mechanical thrombectomy. Do they get thrombolytics first? And this, I will tell you, is an area of a lot of discussion right now, and certainly an area of some controversy. Although the current guidelines on this really don't leave much room for question or controversy, as we'll see in a second. So why would we give thrombolytics to these patients if they're going up to IR? Well, there's some rationale to do so. One is it's thought that it might increase the likelihood of success of thrombectomy. It loosens that clot up from the vessel, for example, makes it easier to pull out. It could result in recanalization of its own. So by the time the patient gets to the IR suite, they've already recanalized. That's a good thing. Maybe it decreases small emboli. When you put that stent inside that clot, a couple pieces could break off. They could go downstream, lodge in a vessel, cause some problems there. If TPA is on board, perhaps it lyses those little clots. Seems reasonable. And what if the mechanical thrombectomy is unsuccessful? This happens sometimes. It technically can't be done. There are tortuous vessels that do not allow them to get the catheter where it needs to be. Well, if you haven't given thrombolytics, then you've robbed them of potentially any kind of meaningful therapy for their strokes. That's the rationale for. Rationale against, hey, this is a risky thing. We don't want to do it if there's no benefit. People bleed. We have people that get angioedema. This is a high-risk medication. We need to be thoughtful about when we give it. Maybe it makes things worse. Maybe it causes the thrombus to fragment or soften up too much, and more pieces are going to break off and go downstream. Don't know. It might delay the time to mechanical thrombectomy, which again, it's a problem. It's time dependent. And then it's a substantially expensive medication to give if it's not providing much benefit to these patients. So the AHA-ASA says, though, hey, this is our guideline. Level 1A recommendation. Patients eligible for ITPA should receive IVTPA even if thrombectomy is being considered. That is unambiguous. And so why is that so unambiguous? The reason is because of those 2015 studies, that in those studies, if the patient was eligible for thrombolytics, they got the thrombolytics. So that was the protocol of the studies that showed benefit in mechanical thrombectomy. That's why this is in the guidelines. But people have started to ask some questions about this, like, yeah, I know that's what they did in the studies, but do we really need to do that? Well, if you look retrospectively at the studies that were done in 2015, looking at mechanical thrombectomy, some got lytics, some didn't. There didn't seem to be any improvement or clear benefit from giving thrombolytics, but that's an unfair comparison because remember, those are different patients. If they were eligible for lytics, they usually got the lytics. So people who are eligible for lytics and people who are uneligible, well, that's two different groups of patients, right? Some of the uneligible group are going to be a longer time from last known well. Some of the patients who are ineligible because of other medical problems that they may have. So they're not the same patients. So that's not a fair comparison. Since then, however, there have been a number of studies, some of them case cohorts, some of them, though, randomized controlled trials that have asked this question, is there a benefit from giving thrombolytics prior to going for mechanical thrombectomy? And I will summarize them in this way. No study has shown a clear benefit of giving fibrinolytics before mechanical thrombectomy. That being said, it's a little bit harder to say definitively that they don't work. So, for example, a recent study published, it was a European study, a lot of EBM doublespeak here, but the study failed to demonstrate the non-inferiority of not giving thrombolytics. So in other words, they couldn't say that it was a non-inferior way to approach these patients. So the question's still out there a little bit. I think it's important to point out, though, that all of these studies I just talked about, looking at thrombolytics, yes or no, they were all done in centers that do mechanical thrombectomy. And that's a different beast, because if I'm at a center that does mechanical thrombectomy, I've got a patient in front of me, the radiologist is ready to go, he's ready to take that patient up and do that thrombectomy. It's only going to take a few minutes to get him up there and get that started. Do I give lytics now or not? Is a very different thing than if I'm in an emergency department of a hospital that doesn't have this service, and I've got to send this patient 2 hours away. to get their mechanical thrombectomy. So that's a different scenario, and it's not been really studied in that particular scenario. So what do we do here? If you're in a center where mechanical thrombectomy is immediately available, some centers give the thrombolytics, some centers don't. I know at my center it can vary a little bit from neurologist to urologist. Follow your institutional protocol and involve your consultants in this decision. If you're in a center where mechanical thrombectomy is not immediately available, but your patient has large vessel occlusion and you're going to send them to get mechanical thrombectomy, yes, give the thrombolytics, drip and ship. That has not changed. All right. Everything we've been talking about up until this moment has been looking at strokes that happen less than 6 hours prior to arrival, or at least the last known well was less than 6 hours prior to arrival. What about the patients who've had a stroke that has been going on a bit longer, or when they woke up with the stroke and we don't exactly know the last known well? These are always patients that have been frustrating because we felt we didn't have a lot to offer them. Well, this is changing, and it's changing pretty rapidly. 2 big studies looked at this, Dawn and Diffuse. I'm sure you've heard of these or probably at least somewhat familiar with it. So let's talk about this. These are patients who've had last known well strokes of more than 6 hours. So it's been more than 6 hours since they were last known well. So they don't really fit into the paradigm of all those prior studies that we talked about. These studies approached a little bit differently from each other. Diffuse looked at patients that were 6 to 16 hours from last known well, and Dawn looked at patients that were 6 to 24 hours. Now, given everything we've talked about today, you should not find this surprising at all that to be enrolled in these studies, the patients had to have a CTA or MRA proven large vessel occlusion. That makes sense. If there's not an occlusion, there's no point in trying to do anything. But another question needs to be asked. If a patient comes in 2, 3, 4, 5 hours into a stroke, you can reasonably presume that they've got salvageable penumbra, that the stroke's not completed, and do the mechanical thrombectomy. But in patients that are further out, that are 6, 12, 18, 24 hours out, you have to ask, okay, there's a clot in the vessel that could be retrieved, but is this stroke already completed? Is that brain tissue already dead? And if so, there will be no benefit to removing that clot. So to be enrolled in these studies, one further thing had to be true, and that is they had to have evidence of salvageable penumbra on perfusing imaging. So in these later strokes, we need to know, does the patient have salvageable penumbra? And so that's where things like perfusion imaging come in. So how did these patients do? Really well. They used a little bit looser criteria for good outcome. They used a modified Rankin score of 0 to 2. And in Dawn, 49% had a good outcome if they were in the thrombectomy group, but only 13% if they were in the control group. Diffuse 3, similar numbers, 45% good outcomes in the treatment group, 17% in the control group. That works out to numbers needed to treat of 2.8 and 3.6. So pretty impressive outcome in this highly selected group of patients that have an LVO and have favorable perfusion imaging. Perfusion imaging. This is maybe something you don't know a lot about. I know it wasn't long ago that I did not really know much about it. We don't have to be experts at this, but I think it helps us to conceptually understand what we're doing here. So the first time I looked at a picture like this, I remember I asked myself, I was too embarrassed to ask anybody else. I looked at this picture and I'm like, what are they injecting into these patients' veins to give them these amazing technicolor images of the brain? And I was really trying to figure that out. And it turns out the answer to it is IV contrast is all that they're giving to these patients. And then what I'm seeing here is a perfusion map. So the way this works is that the patient gets a non-contrast CT of their brain. Then they get IV contrast. And then they take another CT to see which parts of the brain are then lighting up with IV contrast. And then they wait a few more seconds and take another picture. Okay, now which parts of the brain are lighting up? And they do this at several sequential images. So these people are getting multiple CTs in short succession over time to trace the flow of IV contrast through the brain parenchyma. And then putting those CTs together, computer software can generate perfusion mapping, which is what we see here. Let me walk you through this a little bit. So this is a schematic of a normal non-contrast head CT, and this is going to be in a normal non-stroke patient. So you get the non-contrast head CT, and then you give the patient some contrast, and you wait a few seconds and take a picture. You see it light up there? The whole brain lights up a little bit. In real life, this is not nearly as visible to the naked eye. It requires some computer software, but just conceptually, this is what's going on. So wait a few more seconds, and then it lights up even more. There's even more contrast at the tissue. Wait a little while longer, the contrast is washed out, and we look like a non-contrast head CT again. That's a normal person. That's what their perfusion imaging would look like. What about the stroke patient? So we start with a stroke patient and say they have a normal non-contrast CT of the brain, and we give contrast, and then take a picture a few seconds later. Well, part of the brain's lighting up, but there's this big area that's not seeing any contrast. This is the ischemic tissue. It makes sense, right? Contrast hasn't gotten there when this image was taken. Okay, straightforward enough. But let's take another set of images a couple of seconds later, and we see something interesting. I want you to look first at the normal brain and see that it lights up even more, and that center part of that ischemic tissue, it's still not lighting up at all. There's no contrast getting there, but we see this donut around it where there's some contrast, but not as much, and it got there a little bit later. That's the ischemic penumbra. It's getting contrast, it's getting perfusion, it's just taking longer. Why is it taking longer? Because it's getting there via collateral circulation, so it's got a more circuitous route to get there. So this is how we can detect ischemic core from ischemic penumbra from normal brain. And we can calculate a bunch of different parameters. These are two of the most important ones. Cerebral blood flow, how much blood flow is getting to a given voxel of tissue or a given cubic centimeter of tissue. In the core, that's going to be very low, approaching 0. Less than 30% is the cutoff to define the core. The penumbra, on the other hand, is going to see either a normal or near normal amount of contrast. The cutoff, again, more than 30% are predicted because it's getting contrast. It's just taking longer to get there. So the Tmax, this is the time to maximal contrast perfusion, it is going to be elevated in the core. Of course, in fact, for some of the core, it's going to be infinity. It never gets there. In the penumbra, it's going to be increased compared to normal brain. Contrast gets to the penumbra, it just takes longer to get there. So we can create some definitions from this, and that is the total area of brain on the perfusion imaging that has a Tmax of greater than 6 seconds. That's all the ischemic tissue, the core, the penumbra, all of it. The part that has a cerebral blood flow of less than 30 seconds is the core, or less than 30% is the core. And so then we can calculate the penumbra is the total ischemic tissue minus the core, and calculate a mismatch ratio from that, which is the total ischemic tissue divided by the core. So if you have a bigger core, that mismatch ratio number comes down, and vice versa. So the studies used exactly this kind of information, Dawn and Diffuse, to figure out who's got enough salvageable penumbra to make this mechanical thrombectomy worthwhile. Diffuse 3 used strictly CT perfusion criteria. So they said you have to have a core less than 70 milliliters and a mismatch ratio greater than 1.8 and a penumbra of more than 15 milliliters. So you got to have a decent amount of penumbra, and you can't have too big of core, and you have to have a favorable mismatch ratio to be included in that study. Dawn, and I don't want to get into this in too much detail, but it did it in kind of an interesting, different way, where they used a discrepancy between the clinical presentation and the size of the core. So they used some age cutoffs and a couple different cutoffs for stroke scale. But just for example, if you look at the reddish box here, if they have a patient with an NIH score of more than 10, that's a big stroke. That's a pretty disabled patient. So you would intuit from that, if that stroke was completed at that point and everything was dead, then that patient should have a big core. So Dawn said, listen, if they have a big clinical stroke, but their core is small, in this case, less than 31 cubic centimeters, that implies there is a decent amount of salvageable penumbra there. So they use that as their inclusion criteria. So a little bit different. Let's look at a real life example on this. This is a patient I saw just a few months ago. 64-year-old came in and he was not moving his left side. His last known normal was about 10 hours ago. And he had, I don't remember his exact stroke scale, but he was having a pretty significant stroke on examination. So again, our protocol in our institution, someone like this comes in the window between 6 and 24 hours, and they have an NIH of 6 or greater, they get an immediate non-contrast CT, an immediate CTA, and an immediate CT perfusion study if they're more than 6 hours out, like this guy was. So this is his perfusion scan. Let's look at the parameters that we talked about. So cerebral blood flow, just eyeballing this, without being a radiologist, not knowing much about it, you look and say, you know what, those two sides don't look that different from each other. If I look at the left side of the brain, there's maybe a little bit more red and green. If I look at the right side of the brain, maybe there's a little more blue there, but they look grossly kind of similar, okay? You agree with that? Yeah. Compare that to the Tmax, right? So this would be your total ischemic tissue, and we see a huge difference from side to side, right? Look at the right side of the brain there. It is all red and yellow, and the redder it is, the longer Tmax that implies. The contrast is taking longer to get there, or it's not getting there at all. Now, this software is amazing, and so it gives us this perfusion map, but it gives us a derivative perfusion map based on this that makes things even more crystal clear, and it color codes for us all of the areas with abnormal cerebral blood flow and abnormal Tmax. So look at the green images on the right. That is all the areas of the brain that have a Tmax of more than 6 seconds. So in other words, the total area of ischemic brain. The other area with the purple, cerebral blood flow, this is showing us all the areas of the brain where the cerebral blood flow is less than 30%. That's the ischemic core. So as we can see, our total ischemic tissue area is enormous. Our ischemic core is pretty small. So our mismatch volume, which is the penumbra, is 137 milliliters, which gives us a sky-high mismatch ratio. This guy went immediately for mechanical thrombectomy, and he actually had some pretty significant improvement after that. It was a real success story. Now, this is actually a pretty dramatic example. Most of them that you see are not going to look like this, but I think it gives a lot of clarity into what we are looking for in perfusion imaging. So I hope you have a little bit better understanding of that now. You might be asking, though, and as a lot of people are, well, wait a second. So this perfusion image is pretty cool. But if we're using physiologic criteria to decide who has a penumbra and who might benefit in the more than 6-hour window from mechanical thrombectomy, if we're using physiologic criteria, why do we need these arbitrary cutoffs at all? Why stop at 24 hours? Maybe we can keep going. This is a study that did just that. Now, none of this is in the guidelines now. None of this is well accepted as standard practice, so we still stop at 24 hours. But there's signal in the literature that we may be able to keep going. So this is a study that looked at endovascular therapy for people with a large vessel occlusion and evidence of a salvageable penumbra from 24 hours up to 10 days after a stroke. Now, most people are going to have a completed stroke at that point, but there are a number of patients that have a tenacious collateral circulation that are going to maintain some penumbra even for a fairly prolonged period of time. And when they did thrombectomy in these patients, they found benefit. Again, we're talking about a very highly selected small group of patients, but it's evidence that these arbitrary time cutoffs don't make as much sense as using physiologic criteria. So we're going to continue to see this, by the way. This is going to be the next evolution of mechanical thrombectomy using more physiologic criteria. Also, by the way, has a role in deciding who might get thrombolytics. There are already a number of studies in the literature. It's already creeping into the guidelines that maybe for some of these wake-up strokes, we can give thrombolytics beyond 4.5 hours if the patient has favorable perfusion imaging. So it's something we're going to be hearing about more and more, which is why I wanted to share a little bit more about it with you today. So what do we do with all of this in terms of mechanical thrombectomy? What are the decisions that we make at the bedside? I'm going to focus again on the centers that are non-comprehensive stroke centers, because again, this is much easier for me. I got lots of people helping me out with this decision. I've got protocols, I got all the tools. Much tougher when you're at a hospital that doesn't have all of those things. So to start with, some things have not changed. If a patient comes in with an acute stroke, you get a non-contrast head CT right away, and if they are a candidate for TPA, you administer TPA if the patient's agreeable to that therapy. All right, that has not changed. That was true a decade ago. It's true today. So nothing about this endovascular therapy changes that. However, what does change is we have another question we have to answer now, and that is, does this patient have a large vessel occlusion? Because if they do, we know their outcomes are going to be worse, and we know that TPA is not going to work as well, and we know that we have this other therapy that works pretty well for that. So we have to ask that question, and we answer that question by getting a CTA. And we're going to do that liberally with most of our acute stroke patients, if not all. And the timing, again, that's going to depend on the resources that you have at your institution. I will say this, you want to get it as quickly as possible, ideally at the same time as your non-contrast head CT, but you do not want it to cause a delay in the potential administration of TPA. It's kind of the summary of that. It's going to depend on your institution and what you can get done. If you find that large vessel occlusion, and you can get the patient to thrombectomy within 6 hours, don't waste time, get them referred to thrombectomy. Just to bring it right back to the top of the lecture, remember, every 10-second delay costs that patient a day in functional outcome. So refer that patient for thrombectomy. If they have a large vessel occlusion and their stroke is a little older, in that 6 to 24-hour window, we need more information before we can decide if they're a candidate perfusion, and that information is perfusion scanning. That can be done at your institution. It can be done at a receiving hospital if you refer them. There's not one right way to do that. And again, it's resource dependent. If you are at a small hospital that is not going to be able to keep this stroke patient as an inpatient no matter what, then go ahead and just refer them and they can do the perfusion study at the receiving hospital. Some receiving hospitals prefer to do the perfusion study there because it gives them real-time information, not information that's potentially an hour or 2 or 3 old by the time the patient gets there. Reasonable. If you are at a bigger institution where you say, hey, if this patient doesn't need a thrombectomy, I've got neurologists who can care for this patient here, it might make sense to get that perfusion study at your institution before you make that transfer decision. This might also have the added benefit of not overburdening the Comprehensive Stroke Center with stroke patients that don't need their therapies. So again, there are different ways to do this depending on resources. It all comes back to the way we started this talk. You need to have a protocol, know your protocol, and within clinical reason, follow your protocol. It's been a pleasure speaking with you about all of this today. I appreciate your attention. Thank you very much.